I have the great honor of introducing our next speakers and our project we initiated. It's about the consensus paper about TGCT, tenosynovial giant cell tumor. And yeah, I'm really happy and honored to introduce, in the order of speaking, Dr. Sydney Stern. She is a TGCT patient herself and a scientist. She is director of giant cell tumor programs at the TGCT Support, which is a really new organization linked to the LifeRef group, who's been there like forever. So welcome, Sydney. And I think it's fair to say that everybody who has been searching for information on TGCT from a patient perspective has come across the name, so it's a great honor to have you here. I'll just take the opportunity to introduce our next speaker. Also, that's Dr. Silvia Stacchiotti from the National Institute of Cancer in Milan, Italy. She's a medical oncologist, and she's very, very active in the field of sarcomas for many years, I think. She's president of the Italian Sarcoma Group, secretary of CTOS, secretary of the ERTC Soft Tissue and Bone Sarcoma Group, and I think it's again, fair to say that those two ladies have been instrumental to bring this initiative to life, to develop that paper, and to make it a success, really. Welcome. Thank you very much for being here.
So thank you for my introduction. So I'm going to give a little bit of a background on the disease itself and then give you kind of more about my journey. So my name is Sydney Stern, as SPAGN has welcomed me. I have a PhD in pharmaceutical sciences and a master's in clinical research from the University of Maryland, Baltimore. I'm a pharmacokineticist who specializes in rare disease development with the FDA. And I'm the director, more importantly, of TGCT Support and the programs there in collaboration with the LifeRef group. Because I have to say it, and it's very important that the views and opinions presented here today represent those of myself and the speaker alone and should not be represented advice or guidance on behalf of the FDA. So what is tenosynovial giant cell tumor, known as TGCT? This is the disease formerly known as pigmented villonodular synovitis, or PVNS. It's a rare tissue disease that arises from the joint, known as the synovium, or the tendon sheath, or the surrounding tendon. And prior to molecular drivers being discovered, TGCT was largely treated by orthopedics alone in sports medicine as a synovitis, or inflammation of the joint lining. In 2013, a big name change occurred where PVNS and all of the other conglomerate diseases, nodular synovitis, giant cell tumor of the tendon sheath, or tenosynovitis, were all combined into one entity with two very unique subtypes that dictated prognosis as well as typical patient presentation, with the localized or nodular synovitis and diffuse type. More importantly, and what I'm here to talk to you about, is that I'm a patient. I've had this disease since I was 17 years old, so almost the past decade at this point, and I was diagnosed at 17 with TGCT of the left hip, although I had many symptoms for a long time prior. I was never able to walk. I had debilitating pain. Most of the time I spent a long time in a wheelchair, and it's been a major part of my life until college, where I was unable to get up from a seated position, and it could no longer be ignored. Prior, I'd gone to many pediatricians' office, and they chalked it up to some form of growing pains. So it was very discounted throughout my whole childhood. And I thought that it was totally normal to have debilitating pain everywhere you went. Some of you laugh because you know my story and you've heard it many times, and I say that constantly, that shouldn't be normal. And so I went through my journey, and until college, I had been diagnosed with TGCT. And in the subsequent presentation, I will give you some of my medical journey, which started in 2017. But importantly, what you see from my journey is that I stayed primarily in orthopedic surgery and sports medicine. It wasn't until 2018 that I went to a sarcoma center. So starting in 2011, I was diagnosed or I was not yet diagnosed yet, but I had symptom onset where I could not play sports, and the pediatrician related it to growth. In 2014, I had an ER visit because I could not get up, I could not walk, and I was referred to PT. Unsurprising to anybody with the disease, I failed out of PT 12 weeks later, and I was referred to an orthopedic surgeon. In 2015, they diagnosed me with a labral tear and a femoral acetabulum impingement, or FAI, where I went into surgery to fix those. However, what they found is PVNS at the time, now TGCT, and I was diagnosed with that, and you'll hear kind of more about why that specific moment matters. But from then on, 6 months later, I had recurrent symptoms, and I had another anterior arthroscopy. And then in 2016, I had another one. So 6 months later, I had an additional surgery. And I had complications where I aspirated into my lungs and had acute respiratory distress syndrome, and I was hospitalized for 2 months. In 2017 and 2018, I had subsequent surgeries. And then in 2019 is the big hallmark moment of my life where I was transitioned into a sarcoma center. As you can see that this is many, many years after the 2013 redesignation of the disease. In 2019, I had my largest surgery, an open synovectomy with an osteotomy and arthroplasty. So my journey, like many patients' journey, are presented often in a very linear fashion. But the journey is never linear, especially if you've been a patient, we all understand that. And so what's lost from that medical journey is the actual part of the patient journey. And so if we start back at my journey, but look at it from a different perspective, you can see that in 2011, I could not play sports, I was entirely incapacitated, and I thought it was entirely normal not to be able to walk. And 2014, I was rushed to the ER and I could not move. I thought I was never going to be able to walk again. When I was unsuccessful with surgery, I missed many classes. I was late to school, I didn't have a car, and so I had to be transported by friends. And if you could imagine asking anybody for help, as we all have to at one point, it's very difficult. In 2015, when I did have my labral repair and FAI and my first synovectomy, I was told I had a benign tumor akin to a liver polyp, where I would never need treatment again. And to my 17-year-old self, I thought that that was probably the case. I never thought to question the white coat that told me that. And when I was formally diagnosed with the disease, I was handed a piece of paper that was my post-operative report, and I saw the name of the disease. It was never conveyed directly to me that I had this phenomenally rare tumor. In 2016, I had my second surgery. I had barely healed from my first surgery, and I was already rushed into a second one. I was told it was required. It was not an option. As well as in 2016, when I was hospitalized, I was at the time a part-time bartender, and I lost my job, which I desperately required to pay for the PT I just failed out of. And so 6 months later, after that surgery, I had to move cross-country, and I was still on oxygen tanks, and I could not walk or breathe on my own. In 2017, I started my PhD on crutches in an entirely new city, having to navigate streets that weren't made for wheelchairs, doors that weren't made for wheelchairs, and often many people that weren't used to dealing with patients, even in the medical field. In 2018 was my last arthroscopy, and not only did this affect my childhood and my life, it also affected my career and my trajectory, because my candidacy exam had to be moved. Unfortunately, for those that don't know, candidacy exams are a milestone in your PhD career that is extremely anxiety-provoking and decides whether you stay in your PhD. So it's a very big deal, and mine had to be moved so I could have surgery because I could not pipette plates properly anymore because I couldn't sit long enough. And in 2019, I finally made my way to an oncology center. Why, you ask? Like any good student, I was studying for my comprehensive exam or my candidacy. And what I learned from that experience is, wow, I should just put my disease name into PubMed and see what comes up. Something most patients don't think of, right? So I did, and what I found was Dr. Bill Tapp, who many oncologists at this point know. He's very well known in this field, and I kept saying the name over and over and over again, so I made sure that was going to be my doctor. And at no point in my journey did anyone say that I should go to an oncology center. Never. No one ever brought up drug options or anything at all, pretty much. And so when I did acquire that information, I went to my surgeon, and I had 6 surgeons for 6 surgeries, as you can see, over the years. And none of them had ever known that you could refer a patient to an oncology center for this disease. So in 2019, when I did meet Dr. Bill Tapp, I missed 21 days of work in school because of blood tests, lab results, doctor's visits, and I had a complication of a DVT that kept me up at night. All of this was not possible unless I did my own investigations. And what I often tell patients is it should not require someone to have a PhD level education to get the care that they require. And in 2019, my longest stint in a wheelchair for 6 months and on crutches for 3. The United States is not always made for people in wheelchairs, much like many other areas of the world. And I was unable to get into even my lab on my own. The doors swang towards you, and if you're in a chair, you'd have to pull it towards you. So that was not even possible at the time. So now what? What do we do now that we have all of that information? How do we simultaneously treat an underserved area, but a very overtreated disease, particularly surgically? And my journey itself is not unique. There are many patients, even here, who have similar journeys. And it's worth noting that 40% of TGCT patients have follow-ups. And 1/3 of those follow-ups are sought by the patient themselves due to pain. That means overwhelmingly 60% of patients are never seen after they recover from surgery, not only by their own providers, but until they have symptoms. And that is something that would be inherently obvious within my journey, that I never saw a provider after I had surgery. I had to wait until I had symptoms of recurrence and go back and find someone and be re-traumatized by the experience of being diagnosed with this disease all over again. Bernthal et al. Demonstrates that patients who are in active surveillance or monitoring their disease are in less pain compared to those who have surgery or systemic therapies. And this may highlight some severity bias towards patients who are more severe in seeking out therapy, but simultaneously it allows us to consider the idea that instead patients are treated too fast, they're treated too hastily, and they're treated without the consideration of individualized approaches. So effective management of TGCT requires a balance of those risks and the benefits for both surgery or systemic therapies, with the risk of disease progression and recurrence readily part of the decision-making. And I'll let Sylvia cover the rest of that decision-making, but what would have helped my journey throughout the experience is a patient-physician collaborative network. And that's kind of why we're all here, right, is to somehow get involved in a way that has true benefit for patients. And so ways that that could happen in my disease are to reframe early management of TGCT through consensus papers like the one we've developed that emphasize the importance of a referral to a multidisciplinary team approach at the time of diagnosis and for treatment. Similarly, to develop dialogue tools that guide the discussion from non-surgical interventions and surgical interventions at the time of diagnosis. Patients should never be told that I did not give you the option for this drug or this option because I felt it wasn't a good fit. All patients should have at least some knowledge of the options out there for when they do or if they do need it. But lastly, this relies on orthopedic surgeons, orthopedic oncologists, medical oncologists, and all of us to collaborate to change the educational curriculum that makes the initial point of diagnosis or the initial decision point after diagnosis referrals. Referrals to big centers, referrals to centers that know what they're talking about in multidisciplinary teams instead of immediate arthroscopic surgery. And so my journey ended in 2019, as you guys saw, so I figured I will give you where I am now. And thank you everyone for listening. So currently I wanted to highlight that I am no longer the same patient that was in a wheelchair. As you can see, I am now walking, and most people would never know that I had this disease most of my life, or that I would have it probably for another decade from now as well. I have since, in the last 3 years, participated in many hikes and runs. I got my doctorate, I became a fiance, and I've met many patients along the way. It's been truly an amazing journey, and while I am not the child anymore that couldn't even run or walk, I just completed a 5K last Friday. So we do have the ability to change our trajectory in any disease, but it does really truly require thoughtful and considerate providers and physician or clinician and patient relationships. And so lastly, I want to thank SPAGN for having me, as well as Sarah Rothschild, oh, there she is, for giving me the platform that I have to help with patients and a lot of the translation, and inviting me to be part of the consensus. Thank you.
So, first of all, thanks to Catherine and Sydney for being here with me, and to all of you for spending your Saturday together. I am Silvia Stacchiotti, I'm a medical oncologist, and I have to tell everyone this is the first time that my sister was operated for a TGCT. This was 10 years ago. Luckily, she was immediately treated at our institution and was operated by my husband, who is Dr. Gronchi, who is a pretty well-known surgeon in the field of sarcoma. And she's doing fine. But this is just to say that also as a physician, we may experience that these very rare diseases are there, and they are there also in our family. The second thing I want to say is that in my medical oncology life, I started working with patients affected by sarcoma in 2000 in a very, very exciting period of the sarcoma history when imatinib entered the field. And I remember very well patients who were about to die resuscitating thanks to the pill. And so it was very easy to decide, okay, I want to work there. Then I started working in a clinic in which not all patients were suffering of a GIST, but many of them were diagnosed with a tumor that at that time we didn't even know what they were. I remember very well that the first TGCT patient was called a PVNS and was in 2007, and was a patient with a very bulky tumor involving the joint here, and we couldn't do anything. And at that time, the head of my group, Professor Casali, told, okay, you are the right person to work on ultra-rare, in very rare sarcomas, because you like, the challenge of, considering diseases in which there is nothing to do, almost nothing to do. And I'm very proud to say that for some of these very rare sarcomas in 20 years, a lot of things have changed. And this TGCT tumor is a kind of a clear example of this, and I think that we need to congratulate all the community for what we have done together to make progresses in the field. This said, let's start with the consensus paper. These are my disclosure. I, of course, work a lot with companies. Without companies, we do not have any new drugs, so it is impossible not to work together. Oh, sorry, the slides are a bit changed. Okay, anyway, first I want to start with a thank you, because the consensus paper was mostly a volunteer initiative that was started by SPAGN and Catherine, who approached me and Dr. Bauer and asked, would you like to work together on a paper that tries to refine which is the best clinical approach to the disease. So this time, compared to others, was really thanks to the patient invitation that we started this initiative, and I think that it was really an important idea to think about this document. Then, of course, also Sydney joined, and the TGCT support group, and as it usually happens, you need also younger people working together. And so I need to thank, in addition to Dr. Bauer, also Dr. Giacomo Baldi, who is a young medical oncologist who really did a lot to make this position paper done. And then I want to thank all the medical oncologists, surgeons, sarcoma experts who joined the effort, not only working at home, but also coming to the meeting that we had. And there were people traveling from the US, from India, from very far away, just to discuss the document. And I think that without this kind of commitment, it is impossible to finalize this kind of manuscript of paper. So why it is important to spend time in drafting, in writing consensus paper, specifically focusing each single mesenchymal tumor sarcoma type. I needed to go back to a slide that I often present, and I would be very happy if, by looking at it, you may suggest me what is missing in the slides, to try to recall that rarity and heterogeneity that affect mesenchymal tumor and sarcoma are responsible for a limited amount of data, both at the preclinical and clinical level. Usually randomization is not feasible, even though for TGCT this was possible, because even though the incidence is low, the prevalence is not that low in this disease. And this translates into a larger degree of uncertainty when we need to take a clinical decision. On the other side, there are regulatory issues, and both for this reason and for the rarity, these kind of tumors are not very much attractive for the pharmaceutical company. So we have a few studies, often they are not sponsored, and very few approved drugs available for treatment of sarcoma. We were noticing the other day that in Europe, aside for avapritinib and ripretinib, we had no new drug approved for all the 90 different sarcoma type as from 2016. So the last drug which was approved for sarcoma in Europe, aside from GIST, was in 2016. This is just to give you a proportion of the problem. And then, of course, we need to use a lot of label compounds if we want to treat our patient when they are available. And this, again, translates in inconsistency in patient care and patient discrimination. So, and of course, we have less funding. So I think that working on a consensus paper, specifically focusing on each sarcoma type, especially the more rare, helps us improving these aspects. So to make the uncertainty lower, at least we know what all the community thinks is better to do all around the world. Is a very important document to discuss with the regulator, as they at least see that there is a consensus, and can highlight a lot how much off-label use and patient discrimination is a problem in this setting. And so to reach a consensus on the clinical approach to TGCT in particular helps to harmonize the approach to the disease, highlights the need and also the open question. So open the path to what we need to investigate more, not only regarding new drugs, which is of course an important point, but many other aspects, like, for example, how to detect quality of life specifically for TGCT patients and so forth. And it is very important because it helps to take a position as a community. And when then you speak with the regulators, with those who are in the position of taking decision, at least they can see that the community has a position, that we are not all behaving in a different way, and they must take this into consideration. And as I said, this can improve the interaction between physician, patient, and the pharmas and regulators. And indeed, we need to work together. Unfortunately, too often there is a very good connection between pharmaceutical company and regulator, payers on one side, and researcher and patient on the other. But what we often are missing is the direct connection between researchers, patient, and regulators and payer. That should be able to talk of the diseases and of the need, even when the need to discuss a new drug is not there. Probably ahead of this, when there is no apparent conflict of interest, let's say. To work on a consensus paper and in general to improve all the criticisms that we are highlighting, it is of course needed an international collaboration and networking, and we can just see here a small amount, a small part of the groups that are working on sarcoma all around the world. We are very, very, very many, but we need to work together and unify the efforts. It's absolutely stupid to me that we try to do the same thing in different parts of the world without working together. And I think that the strength of patient advocates, and this consensus was an example for this, is exactly to try to put the people, to force people working together. This is, not easy without the help of the patient. And then it is very important to define which is the optimal treatment management and the need of each rare sarcoma. The ESMO guidelines or the NCCN guidelines are, of course, a very important tool to try to harmonize and to provide us the general principle, but they cannot address specifically each tumor type. There is no room enough to do so. And for this reason, I think it is very important, as I said, to develop disease-specific clinical guidelines. And this was done with chordoma some years ago, and helped really a lot the chordoma community to gather together and to try to improve the treatment, even though no new drug are there. So basically, as from the early 2000s, we are, trying to introduce new drug, but we didn't discover. No matter this, the treatment of the disease has improved a lot, and I think that the Chordoma Foundation and the paper were very helpful. And then this was followed by the desmoid consensus paper, the EHE consensus paper, and I'm very, very happy to say that now we have the TGCT consensus paper, and as it was done for the other papers, and especially thanks to the strong work of Sydney, now we have also the live version of the patient. I think that these should be spread everywhere, because very often patients are those who can drive the improvement in the knowledge of the disease, and can, starting from the general practitioner and going to the orthopedic surgeon and whoever else. So I'm very happy with that, and again I need to thank Sydney for this. So the main meeting to draft the paper was organized in Frankfurt on June 21st, 2022, immediately after COVID. At least with that we were lucky. And we decided to have an hybrid workshop to allow everyone to join. It was not bad, even though I don't like very much a hybrid meeting. And of course this was supported by the SPAGN, who organize everything, and this was of much help for all of us. So again, thanks for what you have done. We involved more than 50 experts from 15 different countries, Europe, North America, Asia, and Australia. And we had 10 different disciplines involved in drafting the manuscript and finding the consensus, starting from basic scientists and ending with physiotherapists, through epidemiologists, pathologists, radiologists, surgical oncologists, radiation oncologists, of course medical oncologists, and pain and palliative care physician. And we had, of course, a very important role of the patient representative. And here are some pictures of the hybrid meeting, but before meeting all together, we met very often virtually. So basically, we had to pre-discuss each single chapter of the manuscript within single groups, addressing the medical oncology part, the physiotherapist part, and so forth, so that when we met all together, we just focus on the most critical points. So in terms of methodology, we started with the literature review, what was there in terms of treatment of the disease, but also epidemiology and, for example, quality of life data. By meeting virtually many times, we first drafted a pre-meeting manuscript that was circulated, and all the feedbacks were collected. Then we had the joint hybrid meeting and the discussion of the most critical point, and the final draft, which again was circulated. I mean, of course, incorporated all the changes that we agreed upon during the hybrid meeting, and eventually, we added the submission in September 2022. So it took almost a year from the starting point to the submission of the manuscript. We decided to use the criteria that are applied in the ESMO guidelines for treatment of tumors in general to provide a grade of the level of evidence and the level of recommendation. What does it mean? It means that for the most important statements, after agreeing on what should be done, we decided to specify which are the literature data available to base the decision and which was the level of agreement, because you can even have the situation in which not all the experts and patients agree on what has to be done or not. So this kind of scale, it is used for other position paper, and we decided to apply also to this to our document. Then the paper was published, and thanks to the support of all of you, this is an open access document, so everyone everywhere can access to what is written, and as said, is now translated in English, but I'm sure that this is going to be translated into many different languages very soon, and it can be downloaded from the TGCT support website. Then, what about the contents? So, we have some different paragraphs that are addressing mostly the principle of treatment, but not exclusively this aspect. And if you want, okay, and maybe we can spend a few minutes on the contents. If you get bored, please tell me, because maybe you are not very much interested in the disease. So a very important point when we start drafting a position paper is to try to speak the same language. This is not a given. So, for example, it was very much interesting to me when we started the discussion to understand that the pathologist and the radiologist were referring to a different thing when speaking of nodular and diffuse TGCT. So we had to start the discussion by agreeing on what is what. And indeed, the first paragraph of the position paper tries to define what is considered a nodular TGCT and what is considered a diffuse TGCT. Then, of course, it was important to state that TGCT is not a fatal disease. We have two different subtypes, and we decided to take the definition provided by the pathologist, not by the radiologist, but to avoid any misnaming, if I can say so, we decided not to use localized TGCT, but to use nodular instead of localized, because also diffuse TGCT can be localized. And so we decided to get rid of the word localized and to stick with nodular and diffuse type TGCT. So the nodular type is a tumor that corresponds to the pathological definition of localized type TGCT. So by pathology, you can see in the report localized type TGCT, but we think that it's better to call it nodular type. Please tell me if I'm not clear enough. As I said, we decided to make this selection as it better reflects the imaging findings. So both the radiologists and the pathologists at the end decided that nodular is the right wording. Nodular TGCT usually presents as a single lesion, affecting more often the small joints, arising in the soft tissue, and often evolving over the years with occasional erosion of the bone and the joint surface. Then we have a diffuse TGCT that in the past was also called PVNS. In this case, the disease presents usually with a much more infiltrative pattern, and involvement of the joint structure can be responsible for hemarthrosis and is at very high risk of local relapse even after the complete surgical resection. And then in the paper we also mention the malignant version of TGCT that instead can be life-threatening for our patient, and according to the very little literature and experience we have, can arise de novo more often, or can be the effect exceptionally of a recurrence of conventional TGCT. Personally, I never saw this second scenario. So the cases, the very few cases I had with malignant TGCT were all started, with this definition. They did not change over time, but this is something that is described, so could be there, and it was good, I think, to mention it in the paper. In terms of epidemiology, we have very limited data. We know that the incidence of the nodular type is higher than the diffuse type, and also the recurrence rate after a complete surgical resection is much higher for diffuse type TGCT. You see that here the rate goes from 23 to 72%. Which highlights how much we need the registry to collect more, better data, and maybe in the next 10 years to have a better idea of the real proportion of cases that do suffer of a relapse after a complete resection. And was very important, I think, to state in the document that the risk of relapse is increased outside expert centers. As many patients are not treated in a referral center for TGCT. With regard to imaging, we had a lot of discussion with the radiologists. All agree that MRI is the technique of choice. There were some, insights on which is the best methodology, which is the best way to conduct an MRI in this kind of a tumor. And in the paper, you can see plenty of details on how MRI should be done in the nodular type, in the diffuse type, and so forth. I'm not going through this now. I think that another very important point that we touched was all the limit we have in response assessment after local or systemic treatment. You may know that in oncology we usually use RECIST criteria. These criteria refer to changes in the size of the tumor and consider a response or a progression only when a cutoff is matched. This is not a good way to measure response when a tumor is regular, in the shape of the tumor is regular, as this is for TGCT, and this was very well seen in all the prospective study that we conducted together, in which the activity of the drugs is always underestimated, because we just count cases in which we see a resist response, not all the other in which there is a shrink or a change that is not matching with a resist response. But still there is a lot of work to do, and again this is for the TGCT support group together with us to improve the response assessment criteria. Then was very important, I think, to agree that nodular and diffuse TGCT are the same, a different spectrum of the same disease. They carry the same molecular alteration, which is an alteration affecting colony stimulating factor 1. But I think was important also to clarify that the detection of this alteration is not a requirement for diagnosis, and neither it has, at least for what we know now, a predictive value. So it is not a need to go for the molecular analysis in this case. We also clearly recommended that pathologic review is important, especially when there is a discrepancy between the imaging and the pathologic report, because imaging is very important in a TGCT. In terms of treatment, we started by saying that the disease should be managed within expert centers or network, because not always all the specialties are working in the same institution. So it could even be, like, for example, in Italy, we do not have 10 expert sarcoma pathologists, but probably we don't need it. It is enough to have 3 or 4, and cases can be discussed within a network, a multidisciplinary discussion in which slides are sent to the expert pathologist, but then the patient is treated closest to home. This is the list of the specialists that we think should be involved when the strategy plan is defined. And then we discussed about the diagnostic procedure. We said that in case of a radiologist suspicious for a diffuse type TGCT, a biopsy is recommended before operating the patient. I think this is very important. While we said that the biopsy can be avoided when the radiologic assessment is really very much in favor of a TGCT, and the complete surgical resection is planned. This is to say that sometimes a TGCT is not a TGCT, is a sarcoma, like for example a synovial sarcoma, and we cannot take the risk of debulking a synovial sarcoma. So it is important to be very sure before planning the surgical approach that the diagnosis is the right one. Yes. Yeah. And then, okay. And of course, then we enter the the part more focusing on the treatment, and I think that what was discussed a lot, and Sydney already highlighted it, was the role of active surveillance. That can be the most important decision for very many TGCT patients, and before moving to a systemic treatment in particular, is very important to balance the quality of life of a patient and what is expected to gain with the systemic therapy and the side effects. Okay, and with that, of course, we can go on discussing. What I want, just to, if I can, what I would really love are 2 things. The first one is that this live version of the consensus paper for patient could be the first document that a patient entering the website and searching for TGCT could get in. So I don't know what can you do in this regard, but often patients are not oriented to the right information, to the right place where they can be treated. To have this kind of thing available as the first document, I think would be really great. And the second thing is that I think we should work together to take the most advantage from this kind of thing and show the contents to the agencies before any systemic therapy is discussed, so that they have a clue of what is the disease, which are the needs, and what should be the role of a systemic therapy. So I don't know if there is any possibility, as for example we did for chordoma, to meet EMA, FDA, but this would be, I think, a very important next step.
So thank you very much for this comprehensive overview, and also I think it showed quite clearly how much effort you all put into this initiative, and it was really an amazing experience to be part of that, and I hope it's not the last one. I know we are tight on time, but still I'd like to allow a few questions if there are any. Do we have any questions from the audience? No? Can I just maybe ask one question to the two of you? And it's, I don't know how to phrase it without being like fishing for compliments, but I'd really like to know what your experience is of working together, the experts and the patients. So Sydney, what is your experience? What do you think you changed when bringing in your experience? And Sylvia, what do you think the patients have added to what you could easily have done alone on your own and from expert side? Why involve patients?
I can't do this.
Just start talking.
Okay, you know, maybe? Oh, okay, cool. I think inevitably my background in science had to change something. I think as many of us have realized through advocacy that the translation of scientific information is one of the key components to communicating to patients directly. So it's hard for that not to play a role, right? But at inception of my entire career, I've been a patient. So no matter where I am through my journey, pillaring for the patient has always been a very cultivated, we'll say, skill at this point, since I do work with many stakeholders. But I think the mutual respect is really known in particularly the medical oncologist and the TGCT patient world, that I think that mutual respect for your experience really enhanced, allowing patients to be part of it, and not just at the table, but have a space in which they can convey how they feel about each thing. And I think even some of the conversations were quite controversial, and maybe even patient-led for them to be changed in a manner that would reflect how patients truly want their disease to be cared for.
So first, in this particular case, without patient, we would have not started, because you were the one inviting us. So all is on patient in this case. Then in general, I think that it is very important to have patient on board for very many reasons, starting from wording, because it is good to make what we write the clearest we can, and if you have a different perspective, you can improve a lot wording. And during the discussion, there were critical points like, for example, the role of amputation, and was very important, very relevant to have Sydney, for example, with us. The same was, for example, about radiation therapy, because was a very strong discussion, and to have the position of patient really change the statement, or help, providing the indication in a different way. And then I think that these papers are important for, for the expert community, but the live version is really crucial. And so also to work together on this aspect was really very important to me. So I do not see really, I don't have a name that can, include both the parties, but I think that we really do that together. I don't see two different groups. I see a group that is made by different position, and very often I'm more aligned maybe with the Sydney than with the radiation therapy. So it's just a joint effort and cannot be done without patients.
Yeah, that was felt, that it was a collaborative effort. There was a single goal. Everyone was there for the same reason. And often experts will already see that paper. They'll go to CTOS. They'll already know most of the data. But for patients to bring those papers to their doctors, who are maybe not the biggest experts, has much greater impact overall, and a liability for doctors to then follow that document. So I think hugely impactful.
And for example, the role of senior of patient in improving the paragraph on quality of life, for example, was really crucial, because maybe for us response assessment with an MRI is more relevant than the improvement in pain, and it's good to have someone who brings back all the time symptoms, how to measure symptoms. And
Thank you very much. I just let this stand as you just said, because it's such a nice ending word. So thank you very much for all your work. Also going out, of course, to the whole group that has worked together. It's been amazing. Thank you very much.
No, can I have a question for you? How do you think that we could target the goal of having this kind of document as the first thing that a patient can access when he's searching for TGCT? Do you think there is a way that we can consider, because I think this is very important, and this should go together with a list of the reference centers.
I think you'll find most of the patients here that was their first role in that we play the major role in that community. So the first thing they see when they join our group or any of the groups is this document, as well as a list of specialists that we work with. And so the first thing anyone ever sees when they come to our website or any of the support groups that we have is that document. And so I think the patients that are here know that document by, like, it's our Bible.
Yeah, but
So yeah, I think Silvia, you are talking about investigation, which it goes, I think, through using the site. At least goes as that for Airbnb. But yeah, I think also that you can pay something to put your.
Yes.
So yeah, I think we need some informatic technical. I maybe give to the link some support money. Yeah, no, just I think it's something very informative, but it's feasible in this to improve the indexation of a link.
No, I agree with everything that's been said, and I would add that a lot of our patients come through orthopedics, and usually not orthopedic oncologists. And so I think making the document available at orthopedic societies' websites, I think that's critical for patients, potential patients. But I think that I would think that they would be very excited about having it there too, because they don't want to perform a whoops surgery and say, oh no, what did I just do? They want, they I think would appreciate having a relative zebra like TGCT at the front, so that they know what they know instead of not knowing what they don't know. You know what I mean?
We'll CC you on those emails.
I'm happy to work with Fran Hornacek, who's the president of ISILS and other orthopedic societies. The orthopedics, the presidents of some of these orthopedic societies, I think, would very well receive it.
That's wonderful. Yeah, I think that's our major struggle, is that entry, and orthopedics, especially community orthopedics, may not want to be told by an academic center how to run their practice. And so I think that's one of our major points that we would like to do this year.
I think that's a really good idea, John. And Sydney and I were talking earlier on about the UK, and I was just chatting to Roger about the sort of almost the sort of disjointed service right now, and I think making this more, more present for general orthopedic oncologists would be great. And as John said, no pun intended regarding the word joint in that sentence. So,
so basically dissemination. And trying to be the first, like the hotel blah 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 when you search for Dublin.
Okay, as much as I'd like to continue this conversation, really have to play bad cop here, and we need to stop. But please continue in the coffee breaks, and let's move on to the next session. Thank you very much.